Good afternoon. It's a pleasure to have the chance to talk with everyone. This is a rather interesting topic because I think all of us have seen the move toward the passage of legislation regarding medical marijuana, and certainly some states have now passed laws that legalize the use of marijuana. As we look at this, there are several questions that have to be raised. One of which is, what about medical marijuana laws and pregnancy? Now, it's been an interesting road to get to this webinar. As many of you know, I publish a blog on Psychology Today. And about 2 years ago, I wrote one of my blogs was about the use of marijuana during pregnancy. Got a number of responses and comments on that blog, many of which were very supportive of my views and many of which were rather threatening. It was an interesting response. About a month ago now, I revisited the topic of marijuana use in pregnancy, and especially regarding the medical marijuana laws that were being passed. And once again, it got an explosion of responses, many of which were much more interesting than the blog itself. And I would encourage you, if you want to see some of the attitudes that are out there about discussing marijuana and pregnancy, go to the blog. You don't even have to read the blog, but read the comments. They're quite astounding. And so we did decide, and there have been several calls coming in from people in states that have passed medical marijuana laws. And so that's how we came to the decision to produce this webinar. However, since we put out the announcement that we would be conducting this webinar, I have to tell you, I've received several emails, personal emails, from people that have supported the idea and said, good, we're glad this is going to be discussed. But I also received a handful of emails warning me not to present this webinar. And it's been a very interesting experience. And so what I want to do today is to look at the science around marijuana use in pregnancy. And first of all, I want to be sure everyone understands what this webinar is not about. We are not going to discuss legalization of marijuana use. We're not going to discuss medical marijuana, and we're certainly not going to address punitive measures regarding substance use during pregnancy. As many of you know from my multiple publications on this topic, any punitive measures against pregnant women who are using any kind of substance during pregnancy are completely inappropriate. But we're not going to be discussing that today, and we're not even going to be discussing a woman's right to make choices for her own pregnancy. Now, these are the issues that people have been bombarding me with since we announced this webinar. And I just want to make it clear, we're not going to discuss any of those issues, because when you start discussing those issues, any of those four, it takes us away from the purpose of this presentation. And this presentation is going to focus on a very narrow question. And that question is, with the increasing number of states passing or considering medical marijuana laws and the legalization of marijuana in some states, what responsibility does the public health system have in educating the public about the impact of marijuana on pregnancy and establishing guidelines for the prescription of marijuana to women of childbearing age and pregnant women? Now, we understand this is a very contentious issue, and so we've really worked hard to bring all aspects of the research literature together in order to fully discuss this. And I have to thank the NTI staff, especially Jonathan Lukes, in helping me pull all of the research together. Now, if we talk about marijuana use in pregnancy today, what's changed over the last several years? Well, first of all, the marijuana that's available today is much stronger, and THC concentrations, the active ingredient in marijuana, have been steadily increasing. Now, in the 1970s, the THC concentration in marijuana was 1.3%. By 1985, it was a little over 2%, 93 over 3%, and the latest data we have in 2008, the average marijuana concentration on the streets was almost 9%. So you can see the concentrations of THC have been going up steadily. In addition, Sinsemilla, the bud from the marijuana plant, has even higher concentrations of THC. And you can see in 2008, it was almost 12% concentration. The other issue is that the high potency marijuana sales are becoming more dominant. In 1989, now this is based on seizures by the police of the availability of high potency THC concentration in marijuana. In 1989, over 50% of the seizures of marijuana from the street were low potency, defined as less than 3% concentration marijuana. And high potency marijuana, that is more than 9%, was barely made up maybe 1% of all the seizures. By 2007, that had shifted so that almost 40% of the seizures of marijuana by the police in 2007, almost 40% of those seizures were high potency marijuana. And so you can see, again, not only has the THC concentration increased in marijuana, but these highest levels are more and more available on the streets. The other thing that has changed is that 58% of Americans state that marijuana should be legal, and that's a 10 percentage point jump in just 1 year. And this is a reflection, I think, that public attitudes toward marijuana are shifting, especially toward the perspective that marijuana is seen as a, quote, harmless, unquote, drug. Now, why are we concerned about marijuana use during pregnancy? The national studies out of SAMHSA in 2012 showed that about 11% of pregnancies had marijuana involved. Now, over the last several years, we have been investigating marijuana and other drug use during pregnancy. And our latest data show that from 2008 through 2012, overall, in more than 200,000 women that we have screened with the 4Ps Plus, the overall rate is about 9%, which is not significantly different from SAMHSA's rate of 11%. However, you can see that the rates of marijuana use vary across the country, especially state by state. And what I have listed here are the various states in which we have large samples. Now, these are not statewide prevalence studies. These are data from communities that we work with in each of these states that's listed. So these are not statewide prevalence studies. No one has done that kind of study. But in Oregon, for example, we are working in Southern Oregon. The rate is 17% in pregnancies. Louisiana, these data cover almost all the state of Louisiana. It's 13%. The 10% rate in Hawaii reflects mainly on the Big Island of Hawaii. Illinois is mainly the rural areas of Illinois, and so on. So Nevada is mostly out of Reno and Las Vegas. California is a pretty good spread across the state, and New Jersey is a statewide sample. But I think the important thing here is to look at the variability of rates And the implication is that the rates of marijuana use in your area are going to vary. But the important point is every part of the country has marijuana use occurring during pregnancy. So why is this issue so difficult to even discuss? Well, first of all, there are a lot of opinions, and many of those opinions are based in science and well-informed, and many of those opinions are based in no real information. And this occurs on both sides of the issue. The politics of marijuana intercede with thoughtful discussions, and political parties have taken up the call. The right wing, the left wing, the politics we're seeing in America today, everyone has an opinion that's colored by their own political perceptions. A third reason is much of the science about marijuana use in pregnancy is new and contradicts many of the earlier very well-publicized studies. And finally, I think an issue that we all have to deal with, public law has moved ahead of public health as a source for driving change in this country. And so many times the courts and the law have stepped in before public health has a well-informed opinion based in science to guide public law. So I think those are the difficulties we're facing, and I think these 4 points here are the reason behind so many of the emails I've received that have not wanted this discussion to be held. So what can we do? What I would like to do now is go back and look historically at how information about marijuana use has evolved. And as I've said many times before, it's all about the brain. So historically, I think things got started from a research perspective back in the 60s. In 1964 was the first successful isolation of the active ingredient in marijuana, delta-9 tetrahydrocannabinol, which is, as we know, THC. It was more than 20 years later, in 1988, that the cannabinoid receptors in the brain were identified. So these are the actual places in the brain where marijuana, or THC, has effects in the brain. 2 years later, the specific receptor, CB1, cannabinoid 1, but it's called CB1, that specific receptor in the brain was identified. And surprisingly, what scientists found is that CB1 is the most abundant G-protein coupled receptor in the brain. And they found that this receptor is spread throughout the brain, including the hippocampus, the cerebellum, the basal ganglia, cerebral cortex, and the amygdala. Now, these are very important points. As we go further into this session, we're going to come back, and it's important to remember that this cannabinoid receptor is throughout the brain. In 1992, a new system was identified. These are the endocannabinoids. Now, endo means internal. So these are the naturally occurring cannabinoids in the brain. And what they do is they stimulate cannabinoid receptors. And their action, what has been found by scientists, is the endocannabinoid system is responsible for modulating synaptic neurotransmitter release. Now, what that means, now we all talk about the dopamine or the catecholamine system, the neurotransmitters, and we've talked about other drugs such as methamphetamines stimulate neurotransmitter release. Well, the cannabinoids modulate synaptic neurotransmitter release. And that's what helps regulate motor control, memory, and several other brain functions. And what's interesting, when scientists first isolated the endocannabinoid system, they named the first endocannabinoid they identified Ananda, which is Sanskrit for bliss. And that kind of tells us right there that it was recognized what the role of the endocannabinoid system was. In 1995, numerous other cannabinoids began being identified and have continued to be identified to this day. And in the mature brain, what it was found was that, as I said before, the endocannabinoids act as neuromodulators at the synapse, especially in the presynaptic junction, and they inhibit neurotransmitter release for hours to weeks. And it's this inhibition of neurotransmitter release that, in the hippocampus particularly, that promotes learning. In fetal brain development, it was discovered that the endocannabinoids help shape neuronal circuitry, so how the nervous system is built, and the endocannabinoid system guides the development of the catecholamine system. Now, from 1999 through about 2002, taking what scientists then knew about the endogenous cannabinoids, they began to identify the actions of exogenous cannabinoids, that is, cannabinoids that were from the outside of the body, hence THC. What is the action of THC and other exogenous cannabinoids? And what it was found is that they have a much stronger impact than the endocannabinoids. They're not as subtle as one paper put it. And the exogenous cannabinoids acutely activate the CB1 cannabinoid receptors and interfere with synchronized neuronal firing. Remember, the cannabinoid system helps shape the way the neurons fire. Exogenous cannabinoids, such as THC, interfere with the neurons, the nerves, firing simultaneously. And the other thing they learned is that exogenous cannabinoids decrease the flow of glutamate out of cells. Now, what is glutamate? Glutamate is an amino acid, glutamic acid. Glutamate is important for learning and memory, and it's responsible for communication between nerves, forming memories, and regulating motor behavior. Now, if that's the role of glutamate, and exogenous cannabinoids such as THC decrease the flow of glutamate, what implications does that have? Which brings us to the fetal brain. Now, here are some basic things we know about the brain in humans. First of all, marijuana is highly lipid soluble. That means it gets dissolved into fats very easily. Now, when an element is lipid soluble, that's what helps it cross the placenta and the blood-brain barrier with ease. So being so lipid soluble, fat soluble, helps marijuana move very readily across the placenta. Now, the other thing we know, and this is important, is that in the pre-neuronal phase of brain development, this is the earliest phase of brain development in the human fetus, that phase is about 16 to 22 days after conception. The endocannabinoid system is developing during that time. So the natural cannabinoids are developing during that time, and the cannabinoid receptors and the endocannabinoids actually have a higher density in the fetal brain than they do in the adult brain. And this phase of 16 to 22 days after conception is the period in which the basic scaffolding, the basic architecture for brain structures is beginning to originate. And what are those brain structures that are beginning to form early on? The cerebral cortex, the amygdala, the hippocampus, the cerebellum, the basal ganglia. The same areas we talked about before that have such a high population of cannabinoid receptors. Now, just to help you get oriented, this is a picture of the brain from the outside. And you can see to your left the frontal lobe, up toward the top and back, the parietal lobe. The posterior area is the occipital lobe. The temporal lobe is on the sides, and then you see the cerebellum. Now, importantly, if you peel away the outer shell of the brain, you see the substructure of the brain known as the limbic system. And the limbic system sits right in the midline of the brain. And many of the structures that we talked about previous that I listed out are pointed out here. Well, what do these structures do? The cerebral cortex, the outer shell of the brain, is responsible for higher cognitive functioning, especially abstract thinking, if you will. The amygdala is responsible for emotional behavior, fear, memory, aggression. The hippocampus helps in learning, memory, fear, anger, and motivation. The basal ganglia help regulate movement and reward addiction. And then the cerebellum is responsible for motor control. Now, if you look at this list of brain components that I have here, these are the same components we've already said have high concentrations of endocannabinoid and cannabinoid receptors. So, what are we learning? Now, what I have done in this webinar, and I don't usually do this, but what I've done this time, because this is such a controversial issue, I've listed all of the references for each of these specific points. And on our website, we've already posted the full references. So everything I have listed here, you can go to our website, and there's a button that you can click, and Gabe will explain more how to get to that. And you can download or print out the full list of references. And we've written a short, just 1 or 2 sentence synopsis of what each reference, the main points of each reference. So you'll have a handy list with full references to help you communicate this information. So what do we see with prenatal marijuana exposure, that's PME, prenatal marijuana exposure, and pregnancy outcome? The first point is anencephaly. Now, these were some large epidemiologic studies, and what they showed in these studies is that pregnancies in which the mother is using marijuana are at high risk for anencephaly. Anencephaly is when a baby is born without the whole frontal part of his brain, and obviously will then die soon after birth. What was interesting about the study was they showed that marijuana use in the first month after conception, the first 4 weeks after conception, is when anencephaly occurred at a higher rate. If marijuana use occurred after the first month of following conception, there was not an increased rate of anencephaly. So it's a very particular time in pregnancy, the first month after conception, which, as we already talked about previously, remember we talked about the preneuronal phase being 16 to 22 days after conception. That's when the neural tube is forming, and that's when the cannabinoid receptors, the endocannabinoid system, are developing. It's during that phase that, as the neural tube forms and closes, that's how the forebrain, the front part of the brain, is formed. And marijuana use during that first month, which is when most women don't even know they're pregnant, marijuana use during that first month produces an increased risk of anencephaly. Also, several studies have shown that there is decreased fetal growth. Now, this is one of the more controversial areas. There are a number of studies that show that marijuana use, even when controlled for other substances and other factors, there is a decreased rate of fetal growth. On the other hand, there are a couple of studies that show no impact on fetal growth. Animal studies do support decreased fetal growth evidence, and I have 2 of those studies listed there. And then a study that came out just last month in January of 2014 showed that even when you control for tobacco use, there is an increased rate of stillbirth in pregnancies in which the mother is using marijuana. Now, stillbirth rates are significantly increased in tobacco affected pregnancies, so that we know many women who smoke marijuana also smoke tobacco. And so that could be confounding part of the findings here. But even when the epidemiologists controlled for the tobacco use, there was still an increased rate of stillbirth. Now, neurobehavior is the way an individual interacts with and responds to the environment, to the world around them, whether it be stimuli such as light or sound, or whether it's the human voice or face. But the way, in this case, the neonate, the newborn, responds to the world around him, that's what we're talking about when we talk about neurobehavior. And there are many studies that have looked at this issue of neurobehavioral changes in infants whose mothers have used marijuana. The earliest studies were done by Peter Fried and his group up there in Canada. And what they found was that infants whose mothers, when they controlled for other factors, infants whose mothers used marijuana had higher rates of problems with habituation, that is, tuning out negative stimuli. They were more irritable and had more tremors. Dahl et al. In 1989 followed that up with another study that showed that this translated to sleep disturbances. Our own work was very consistent with the work of Fried and Dahl, in which we found problems in state regulation, the ability of the infant exposed to marijuana, the ability to regulate his state of arousal. Coles and their group out of Atlanta found problems with orientation and, again, state changes. Now, there have been some studies that have not found any neurobehavioral difficulties, one of which is a very well-publicized study out of Jamaica, which did not find any abnormalities in the infants. And then the most recent study, Barros and his group in 2006, again found, similar to all the early studies, problems with state regulation, arousal, and excitability in the infants. Now, as everyone knows, when we try to do studies of children who have been exposed prenatally to any type of substance, you have multiple environmental factors that come to play. And the difficulty, because you can't do a randomized controlled study and tell pregnant women, you use marijuana, and another group, you don't use marijuana, and do a controlled randomized study, that's why we have to rely on animal studies. But the human studies that have been done and have made good attempts at controlling all these other factors have found that long-term there are impaired cognitive and neurocognitive skills and deficits in behavioral functioning. And I think if you could summarize all of this, there was a study, a paper published by Peter Fried again, that looked at all of these studies, long-term studies, and what he found is when you put all of these studies together, the main difficulty of young people who were exposed to marijuana prenatally, long term, the main difficulty is difficulties in executive functioning, the ability to plan and complete a task, to stay on task, to pay attention. So that's executive functioning, and that's exactly, if you remember all the different parts of the brain we talked about and the parts that are affected, it's how you bring all of that together. Now, this is not global cognitive functioning. This isn't IQ. IQs of children prenatally exposed to marijuana are normal overall, but it's their neurocognitive skills, their executive functioning, and how you bring behavior into executive functioning and how executive functioning affects behavior. That's where the difficulties lie. Animal studies have shown the same thing, especially memory deficits and hyperactivity. And what the animal studies found was that many of the difficulties demonstrated by the animals, the prenatally exposed animals in these studies, it was based on a documented decrease of glutamate outflow in the hippocampus. The exact same thing we were talking about that was discovered in the earliest studies of the effect of exocannabinoids. Nancy Day and her group out in Pittsburgh studied adolescents, and they have had one of the longest term studies of prenatally exposed youth, following them since pregnancy all the way through into the teen years. And what they found in their study was an increased risk of adolescent marijuana use. And they did make every attempt to control for all the other factors that can influence the decision to use marijuana, and they did still find an increased risk of use. And then most recently, there was a study of functional MRIs, and this is where it gets really exciting because now we can actually look at brains, and so there are groups that are doing MRIs. This was a study in 2006, functional MRIs in 18 to 22-year-olds who had been prenatally exposed to marijuana. And what they found on the functional MRIs was altered neural functioning that impacted short-term memory. So again, if you go back to the earliest basic science studies about exocannabinoids, endocannabinoids, cannabinoid receptors, their distribution in the brain, the multiple areas of the brain that can be affected by marijuana, and you bring it all together and look at this slide in particular, you can see it all does come together. It does make sense. So, the argument that marijuana is a harmless drug is no longer valid. We have to recognize that there are multiple ways to measure harm. And just because a young person is fully functioning and is very bright, there are aspects of his life that well could have been affected by prenatal exposure to marijuana. And this is where we have to realize that the issue of marijuana use during pregnancy has to be placed into the context of alcohol use in pregnancy and tobacco use in pregnancy. Marijuana is rapidly becoming a legal drug, and so we have to look at it from a public health perspective. Now, in summary, why do I say marijuana is not a harmless drug? First of all, we know it crosses the placenta and accumulates in the fetal brain. Remember, it's lipid soluble. Lipids are fat. The brain is made up of almost all fat. Secondly, marijuana interferes with neuronal cell development in the fetal central nervous system. And importantly, animal studies are documenting many of the same effects as human studies. This means we do have to face up to the policy implications that are out there. Marijuana is thought to be a useful treatment for a variety of illnesses, including chronic pain. However, you have to understand there are very few randomized controlled studies that document marijuana as a useful treatment. And when drug companies create new drugs, they have to go through a whole series of very specific types of testing and studies to make sure that the drug works. As we pass medical marijuana laws, do we have those studies in place? And a group of psychiatrists in California asked the question, if we're to write medical marijuana prescriptions, what dose do we write? And it's a very good question because the answer is no one knows. The second policy implication, women have an equal right to appropriate treatment as men. So if marijuana is a useful treatment, then women have to have access to it. And finally, public law has moved ahead of public health. And I'm repeating that because that's where the difficulty lies. Marijuana, especially medical marijuana, should be a public health issue, not a political or legal issue. So what are my recommendations? Number one, public health policy should consider marijuana in the context of alcohol and tobacco. Now, what are the implications of that? Medical marijuana legislation should include, number one, public, professional, and legislative education about the impact of marijuana on pregnancy and child outcome. There are several studies that are now implicating marijuana's impact, and we need to have everyone aware of those studies so that informational materials about marijuana use in pregnancy should be available at all sites. And a government warning label, similar to alcohol use during pregnancy, should become a part of legislation. So just like there is a warning label in many states about alcohol use during pregnancy, that warning label should be attached to marijuana when it is sold. Medical marijuana legislation should require CMEs on marijuana and pregnancy for physicians who are going to write marijuana prescriptions. Who are those physicians that are writing the marijuana prescriptions, and how much do they know about marijuana's use and its impact on adolescents and impact on pregnancy? And there should be guidelines for physicians who are writing marijuana prescriptions. Should we require all physicians ask about the possibility of current pregnancy before they write the prescription? And should we require physicians to at least offer pregnancy testing to all women of childbearing age prior to giving the prescription? Now, I'll give you a good example of that. There is an anti-seizure medication called Depakote. And Depakote, it's known, has impact on pregnancy and child outcome. And so the standard of care is, if you're going to prescribe Depakote to a woman of childbearing age, you're going to at least offer, if not require her to have a pregnancy test before you will give that prescription. Now, I'm not saying that we should require women to have a pregnancy test before they get a marijuana prescription, but we should at least be offering that opportunity to them. What research needs to be collected? We need randomized controlled studies of the effectiveness of marijuana as a medication. We need to understand physician attitudes, knowledge, and participation in writing medical marijuana prescriptions. I don't know of any state that's actually tracking marijuana prescriptions and looking at where those marijuana prescriptions are being written, who's writing them, and what information physicians have as to guide them in writing prescriptions. And especially with all the new medical marijuana legislation being passed, it's an opportune time to study rates of marijuana use in pregnancy prior to the new medical marijuana legislation and then following implementation of the new medical marijuana legislation. These studies have not been done, but it's going to be important for us to understand the impact of this legislation on our communities as a whole. We need to do longitudinal tracking of the frequency of marijuana prescriptions. Are they becoming more frequent or less frequent? We need to look at rates of anencephaly over time. No one has ever studied this, especially in relationship to new marijuana prescriptions being written. Prospective longitudinal studies of child cognitive and neurocognitive development need to be continued and expanded. And we have to look at studies of family functioning. If there is someone on medical marijuana prescription, does it interfere in any way with care of the child? One would think not, but we don't know that for sure. And so we need to look at these issues. And so I want to thank you for joining me. I hope, if nothing else, this webinar has raised some questions that we all can begin to look at and address. And I think the bottom line that I would want to emphasize is it's time for public health to step up and to develop policies based on science that are good for both the mother and the child.